This video will focus on electrolyte imbalances. The objective is to describe clinical manifestations of nursing management of disorders that include sodium, potassium, magnesium, calcium, and phosphate imbalances. Body fluids and electrolytes play an important role in maintaining a stable internal environment of the body. A variety of adaptive responses keep the composition and volume of body fluids and electrolytes within the narrow limits of normal to maintain hemostasis and promote health. Many diseases and their treatments could affect fluid and electrolyte balance and alter hemostasis. Water is the primary component of the body, accounting for about 50 to 60% of body weight in the adult. The two major fluid compartments in the body are the intracellular fluids, or inside the cells, and the extracellular fluid that is outside the cells. Extracellular fluid is composed of interstitial fluid, plasma, and transcellular fluids. Transcellular fluids include cerebrospinal fluid, fluid in the GI tract and joint spaces, pleural, peritoneal, intraocular, and pericardial fluid. Important to remember as we move forward that 1 liter weighs 2.2 pounds or 1 kilogram. Electrolytes are substances whose molecules dissociate or split into ions when placed in water. Ions are electrically charged particles. Cations are positively charged. Examples of positive cations are sodium, potassium, calcium, and magnesium. Anions are negatively charged ions, and examples of anions or negatively charged ions are bicarbonate, chloride, and phosphate. Most proteins bear a negative charge and thus are anions. Diffusion is the movement of molecules from an area of higher concentration to an area of lower concentration. Eventually, the sugar molecules are evenly distributed. Facilitated diffusion involves the use of a protein carrier in the cell membrane. An example of this is glucose transport in the cell. The large glucose molecule must combine with a carrier molecule to be able to cross the cell membrane and enter the cells. Active transport. Molecules move against the concentration gradient. External energy is needed for this process. The sodium-potassium pump. The sodium diffuses into the cell, and the potassium diffuses out of the cell. So the active transport system supplies energy and delivers sodium back into the extracellular compartment and potassium to the intracellular compartment. And this is adenosine triphosphate. Osmosis is the process of water movement through a semi-permeable membrane from the area of low solute concentration to an area of high solute concentration. Osmolality is the preferred measure to evaluate concentration of plasma, urine, and other body fluids. Changes in the extracellular fluid osmolality can cause significant changes in the intracellular fluid osmolality, and these changes can affect normal cell function. 2 times the sodium equals osmolality. So we know that a normal plasma osmo is between 280 and 295. If you have a greater than 295 osmo, you're looking at a patient that has a water deficit, who's dehydrated. If you have someone that has an osmo of less than 275, you're looking at someone who has water excess, who's overhydrated. The effects of water status on red blood cells is demonstrated in this photo. A shows hypotonic fluids. Water excess indicates that there is cellular swelling. An isotonic solution is a normal water balance that has no change in the cell. And in C on the picture, we have hypotonic solution. There's a water deficit, and you can see that the cells are shrinking. The osmolality of the fluid surrounding cells affects them. Fluids with the same osmolality as the cell interior are isotonic. Normally, extracellular fluid and intracellular fluid are isotonic to one another, so that no net movement of water occurs. Changes in the osmolality of extracellular fluid changes the volume of the cells. Solutions in which solutes are less concentrated than the cells are hypotonic, hypoosmolar. If a cell is surrounded by hypotonic fluid, water moves into the cell, causing it to swell and possibly burst. Fluids with solutes more concentrated than in cells or an increased osmolality are hypertonic or hyperosmolar. If hypertonic fluid surrounds a cell, water leaves the cell to dilute the extracellular fluid. The cell shrinks and may eventually die. The dynamics of fluid exchange between a capillary and tissue are demonstrated here. There's an equilibrium that exists between the forces, filtering fluid out of the capillary and forces absorbing fluid back into the capillary. The hydrostatic pressure is greater at the arterial end of the capillary than at the venous end. The net effect of this pressure at the arterial end of the capillary causes a movement of fluid into the tissues. At the venous end of the capillary, there is a net movement of fluid back into the capillary. Edema is caused by fluid shifts. First spacing is the normal distribution in intracellular fluid and extracellular fluid. Second spacing refers to the abnormal accumulation of interstitial fluid, which we normally call edema. And third spacing is the fluid is trapped where it's difficult or impossible for it to move back and forth into the cells or the blood vessel. The effects of stress on fluid and electrolyte balance is demonstrated here. You can see that cardiac regulation uses natriuretic peptides, the BNP. GI regulation is related to oral intake. So if your patient has nausea, vomiting, or diarrhea, this could affect their electrolyte imbalance. The adrenal cortical regulation releases hormones to regulate water and electrolytes, glucocorticoids, cortisol, and mineral corticoids, along with aldosterone. Osmoreceptors in the hypothalamus sense whether there's a fluid deficit or increase. Whenever we have a deficit, the receptors are going to stimulate thirst, and antidiuretic hormone, ADH, is released. We decrease plasma osmolality, or water excess, then would suppress the ADH release. And the kidneys are going to be the main organ for regulating fluid and electrolyte balance. The assessment of skin turgor, which you've had in health assessment, we can see that when normal skin is pinched, it resumes its shape in seconds. If the skin remains wrinkled for 20 to 30 seconds, the patient has poor skin turgor. Hormonal changes include a decrease in renin and aldosterone and an increase in ADH and ANP. Subcutaneous tissue loss leads to an increased moisture loss. So fluid volume deficit, or hypovolemia, is the abnormal loss of body fluids or an inadequate intake of fluids or plasma or interstitial fluid shift. Dehydration is the loss of pure water without a corresponding loss of sodium. We need to correct the underlying cause and replace the water and electrolytes. We can do this orally, or with blood products, or with isotonic IV solutions. On the other hand, fluid volume excess is also termed hypervolemia, or excess fluid intake, abnormal fluid retention, or an interstitial to plasma fluid shift. The clinical manifestations of fluid volume excess include weight gain, which is the most common. The interprofessional care would be to remove fluid without changing the electrolyte composition or the osmo of the extracellular fluid. To do this, we would use diuretics, fluid restrictions, possible restriction of sodium intake, or removal of fluid to treat ascites or pleural effusion. Isotonic gains and losses affect mainly the extracellular fluid compartment, with little or no water movement into the cells. Hypertonic imbalances cause water to move from inside the cell into the extracellular fluid to dilute the concentrated sodium, and this causes cells to shrink. Hypotonic imbalances causes water to move into the cell, causing cells to swell. So here we have a patient that has prolonged vomiting, and the nurse monitors for fluid volume deficit because vomiting results in what? And the correct answer is the fluid movement from the cells into the interstitial space and blood vessels. Fluid volume deficit occurs when there is a loss of both sodium and water. Intracellular fluid moves into the interstitial spaces and the blood vessels. So the correct answer there is A. So nursing management of fluid imbalances. So some of the problems that we would have with fluid volumes, we would have hypervolemia or hypovolemia. There could be a knowledge deficit on how to manage the fluid volume situation. You could have a patient with impaired skin integrity, an altered blood pressure, impaired respiratory system function, impaired urinary system function. The patient could be at risk for injury, risk for impaired skin integrity. So some of the things we'll need to do for these patients is daily weights, I&O, cardiovascular care, respiratory care, patient safety, and skin care. We want to give IV fluids as ordered and carefully monitor the rate of infusion, making sure we're looking at the site every hour to check that it's not infiltrated or phlebitic. If applicable, we're going to maintain an adequate oral intake and assess the ability to obtain adequate fluids independently. Can they express thirst, and can they swallow effectively? And we have to assist them with their physical limitations. So here's a slide that demonstrates the effects of hyperkalemia, someone that has a high potassium. And this could be caused by an impaired renal excretion, shifts from the intracellular to extracellular fluid, maybe someone that has a massive intake of potassium, maybe some drugs. This is seen very commonly in patients with renal failure. And this is what you would see if the patient was had an EKG done, or if they're on a telemetry unit and their EKG is being monitored. So life-threatening arrhythmias can occur with a high potassium. Other manifestations include fatigue, confusion, tetany, muscle cramps, weak or paralyzed skeletal muscles, abdominal cramps, or diarrhea. So the treatment for this is to stop the oral or IV potassium intake, maybe increase the excretion of potassium by giving them diuretics, like a thiazide diuretic, or put them on dialysis. Or we can give a drug called K-Exolate, which binds with the potassium and is excreted from the body. We can force the potassium from the extracellular fluid to the intracellular fluid by giving them a combination of IV regular insulin with dextrose, or giving them an IV infusion of sodium bicarbonate. This is a short-term fix, because if the potassium is that high, they're probably going to need hemodialysis to remove it to prevent them from having a life-threatening dysrhythmia. This is a picture of the effects of low potassium. So the clinical manifestations of a low potassium, cardiac is the most significant. So you could have fatal cardiac dysrhythmias. There could be skeletal muscle weakness and numbness and tingling, weakness of the respiratory muscles, a decreased GI motility, hypercalcemia. And some of the treatments, then you'd want to give them potassium as a supplement, either orally or IV. It's always important to remember that you always dilute IV potassium. You never give IV potassium IV push. It always has to be diluted. And if it's given through a central line, you can dilute it in a small amount of fluids. Otherwise, you have to dilute it, and if it's given peripherally in a large volume of fluid, 250 to 500 or more. So never give IV potassium IV push, or the patient would die. The rate of potassium when you give it IV should never exceed 10 MEQs per hour. You always want to give this on an infusion pump. This is a picture of testing for a low calcium level using the Phosphate sign, which is demonstrated in picture A, which is a contraction of facial muscles in response to a light tap on the facial nerve in front of the ear, or B demonstrates the Trousseau sign, which is a carpal spasm induced by inflating a blood pressure cuff above the systolic pressure for a few minutes. So hypocalcemia is significant. Calcium is important for the formation of teeth and bones, and blood clotting, helps to transmit nerve impulses, helps with cardiac contractions, muscle contractions. And we usually, our major source of intake is dietary, but along with our intake with the diet for calcium, you also need to have vitamin D to help us absorb it. Sodium imbalances are associated with changes in osmo. So this plays a major role in the extracellular fluid volume and concentration. And you would see generating and transmitting nerve impulses, muscle contractivity, and regulation of the acid-base imbalances. The signs and symptoms of a high sodium then would be the thirst, changes in mental status, can be anywhere from drowsiness, restlessness, confusion, lethargy, seizures, or coma. And symptoms of high sodium would also be similar to a fluid volume deficit. So these can occur with inadequate water intake, excess water loss, or sodium gain. Causes include hyperosmolality leading to cellular dehydration. And our body tries to protect ourselves from this by being thirsty. So you want to try to treat the underlying cause. So if it's a primary water deficit, replace the fluids orally or with IV isotonic or hypotonic fluids. If it's from excess sodium, you're going to have to dilute or with sodium-free IV fluids and promote sodium excretion with diuretics. For those that have a hyponatremic, if the cause is water loss, you're going to restrict the fluids, and that could be the only treatment. Or you could use loop diuretics. If the symptoms are severe and include seizures, the patient may need to have 3% saline infusion. 3% saline is a hypertonic solution. If the cause is abnormal fluid loss, then you'd need to replace the fluids with an isotonic sodium-containing solution. Try to encourage the patient to have oral intake. Don't give diuretics. And some of the drugs that could be given would be to block vasopressin or an antidiuretic hormone. So potassium is a major intracellular cation, and you can see why it's important. We get potassium from protein-rich foods, fruits, vegetables, salt substitutes. Medications can be given either orally or IV, and it's also stored in blood, and it's regulated by the kidneys. The manifestations of hypercalcemia include fatigue, lethargy, weakness, confusion, hallucinations, seizures, coma, dysrhythmias, bone pain, fractures, kidney stones, polyuria, and dehydration. The treatment then for an elevated calcium would be to restrict calcium in the diet, stop medications that are related to high calcium, increase weight-bearing activity, increase fluids to at least 3,000 to 4,000 milliliters a day. Cranberry juice or prune juice is an option. Hydration with isotonic saline infusion. And the gold standard is biphosphates or calcitonin. Manifestations of low calcium include, as we talked about before, the positive Trousseau's or Chvostek's sign, laryngeal stridor, dysphagia, numbness and tingling around the mouth or in the extremities, and dysrhythmias. The treatment would be to treat the cause, give calcium and vitamin D supplements, IV calcium gluconate, rebreathing into a paper bag, treat pain and anxiety to prevent hyperventilation-induced respiratory alkalosis. Phosphate is a primary anion in the intracellular fluid, and you can see it is also essential to muscles, red blood cells, and the nervous system. The levels are controlled by the parathyroid hormone. Maintenance requires adequate renal functioning. And we know that calcium has a reciprocal relationship with calcium. So what that means is if someone has a high elevated phosphate, their calcium is low. If they have a high calcium, their phosphate is low. And we will see this with patients that have renal disease and how we treat their elevated phosphorus and low calcium on a regular basis. And we'll be seeing a lot of patients with renal disease when we go to the hospital. Hyperphosphatemia is caused by acute kidney injury or chronic kidney disease. So some of the manifestations are tetany, muscle cramps, numbness, hypotension, dysrhythmias, and seizures. There could be calcified deposits in the soft tissues such as the joints, the arteries, skin, kidneys, and corneas, and that can cause organ dysfunction. Most notably, it can cause renal failure. You want to treat the underlying cause, restrict fluids and foods that have phosphorus in, give them phosphate binding agents. They may need dialysis, volume expansion and forced diuresis, and you want to correct any low calcium that they have. Hypophosphatemia, which is a low phosphorus caused by malnourishment, diarrhea, or the use of phosphate binding antacids. So here we're going to have central nervous system depression, muscle weakness and pain, respiratory and heart failure, rickets, among others. So the treatment then would to increase the oral intake with dairy products, oral supplements, administer IV sodium or potassium phosphate. And these patients will need their calcium and phosphorus monitored every 6 to 12 hours. Magnesium is another important electrolyte that helps with blood pressure regulation, blood sugar control. It's needed for ATP production. Manifestations of hypermagnesemia and elevated magnesium include hypotension, facial flushing, lethargy, nausea, vomiting, impaired deep tendon reflexes, muscle paralysis, respiratory and cardiac arrest. So the management is you want to prevent this from happening. So make sure that you stop magnesium-containing drugs, limit the dietary intake of magnesium-containing foods. If the patient is symptomatic, you would reversal agent would be IV calcium gluconate. Fluids and diuretics are given to promote urinary excretion, and in worst case scenario, the patient would need dialysis. Hypomagnesemia then is caused by prolonged fasting or starvation, chronic alcoholism, fluid loss from the GI tract, parental nutrition without supplementation, and it could be caused from different medications. So the manifestations are going to be similar to low calcium: muscle cramps, tremors, hyperactive deep tendon reflexes, a positive Shavastic and Trousseau sign, confusion, vertigo, and seizures, and again, dysrhythmias. You want to treat the cause, give them oral supplements, increase the dietary intake of magnesium, and if it's severe, you're going to give them IV magnesium supplements.